Mm. All right, I think we're live. Hello, folks. All right, sorry, it takes me a minute to get this thing started. I need to have a sign or something. Anyway, hi, I'm Metta Spencer, and I'm in Toronto with some new friends who are sitting on my screen, but they're in front of their own webcams in various places. One of my new friends is Ronald St. John, who's a public health physician, an epidemiologist, who's worked in public health all his life, and who in fact was in charge of the SARS epidemic when it came to Canada. Thank goodness he handled that all right. And he's worked in he's been in charge of infectious diseases, I think he said, for the Western Hemisphere. So that's a lot of disease to handle, Ronald. And I'm glad you're here with us to tell us about it. And then we will also next see Dr. Bryna Warshawsky, who is also here in Toronto at her office, I take it, in the Public Health Office of Ontario. Is that the institutional affiliation? Is that how I'm supposed to describe you?
Yeah, it's Public Health Ontario, and I'm at my home in London. But the office is in Toronto, but we have offices all over the province.
Okay, very good. I'm glad to know where you are. And then we have a newcomer, Sweta Chakraborty. I beg your pardon. I said
very close. Chakraborty.
Very good. And Dr. Chakraborty is a behavioral scientist who's very interested in the perception of risk and how it is that people tend to deny risk and what needs to be done to make it easier for people to acknowledge danger. And of course, that's relevant to a whole bunch of different dangers. And in fact, she's done work not only on epidemics, but also things like water safety and global warming and a variety of other global threats. So I'm glad that all three of you are here. Sweta is connected with an organization called EcoHealth Alliance. And I think their main mission, I think they're in New York City, and their main mission seems to be studying the connection between animal diseases in the wild, in Africa and places, and the transmission of these viruses to human beings. So maybe she can tell us about that in a bit. But let's start off by asking Bryna to just brief us on what is the situation. We have nice hospitals, and I think some of us wash our hands once in a while, and we feel pretty healthy. But I've been told that we should be a little bit more nervous than we really are, because there are pandemics possible that we should be expecting more to encounter in the future. So Bryna, can you tell us what's the status of affairs about global health?
Sure. So I'd be pleased to. Maybe to start with, we should define just a couple of terms that might help. So the first term is the word we call endemic. So endemic means that a disease is here and we have it on a regular basis and we see it all the time. So something like sexually transmitted diseases or diseases that cause diarrhea and vomiting like salmonella and campylobacter, those are endemic. We see them all the time. Versus something that we call epidemic or an outbreak. So that's by definition something that occurs more than the usual. So when SARS appeared, that was something we never had before. That was clearly an epidemic or an outbreak. And then there's the word that we use called pandemic. So pandemic is sort of a worldwide, spreads across the world, new infection. And I guess HIV would be an example of a pandemic, something we never had before, and now it's all across the globe. And traditionally, when we think about pandemic, another thing we often think about is influenza, an influenza pandemic. So a new strain of influenza that appears, that spreads all across the world. So we have influenza every year. Every year we have seasonal epidemics or outbreaks of influenza, usually in the winter. But a pandemic is a new virus, a new type of influenza or a new other type of virus that appears. We don't have any protection for it because it's so new. Our immune system has never seen it before, and it just spreads across the world. And that's what we're really concerned about when we talk about pandemic. But we're also concerned about epidemics or outbreaks. And there are a lot of new, usually viruses, that have emerged. So if you look back 50 years, we didn't know about HIV, we didn't know about West Nile, we didn't know about Lyme disease. There's a whole bunch of bat-related diseases we didn't know about. So these things are emerging all the time. We didn't know about SARS, like SARS was not on our horizon. And so those things arise and cause these outbreaks, which can be confined to one country or across a number of countries like SARS can, or can spread around the world like HIV did, or like we worry about influenza. So really what we're thinking about when we talk about pandemics or large outbreaks is usually a new virus emerges out of, usually from animals, spreads into people. We don't have any past exposure to it, so no immunity, so we can't fight it off. It spreads easily from person to person, and it can be what we call quite virulent. So it can cause a lot of people to get quite sick and to end up in hospital, and can end up causing fatalities or deaths. And the sort of prototype of that was the 1918-19 pandemic, which was influenza, which we see every year, but that was a very aggressive strain of influenza, rapidly spread around the world, was carried by the soldiers as they came home from the First World War, killed more people than the First World War, killed people who were young and healthy. And so when people think of pandemic, they often think of that influenza pandemic, and that's an idea of how bad it could be. So we do know that influenzas have new strains emerge, and every few years or decades, we do get a pandemic of influenza. So we can probably expect to see influenza, another pandemic sometime, we don't know when, but another virus could also emerge and do that same kind of thing. And it could emerge from animals like HIV did, and then be sort of brewing in people for a number of years, and then start to spread across the world. So we really don't know what the next one will be, except we know flu will probably cause another pandemic, but it could be another virus as well. And that's our challenge at the moment. So hopefully that sets a bit of context or background for our discussion.
Yeah, can you, one of the questions that emerged as you were speaking was, I was wondering how much of it is like a mutation of an existing germ. So you have a new strain. Is this like there's actually a spontaneous mutation or something of that kind? Or are most of these something brought in from a new animal that had been there before? In other words, how much of this is new stuff and how much of it is really out there in the wild waiting to jump on us when it gets a chance?
Well, a lot of it is sort of exists in other animals for a number of these diseases. Like for HIV as an example, it existed in animals, or a form of it existed in animals probably for a long time, probably in people for a long time before it started to efficiently sort of spread from person to person. Some of these diseases existed in bats before they got into people. So some of it is sort of what we call a zoonotic disease. It's a disease that's in an animal that gets into a person and then behaves differently in the person than it did in the animal. With influenza, we know that there's multiple strains of influenza that exist predominantly in birds and also in pigs. And what happens with influenza is that it can mix up all its genetic material, and sort of a new strain emerges that we've not seen before, that then if it has the ability to spread person to person, it can cause a pandemic. So for influenza, we know it probably comes from birds or potentially from pigs, where a bunch of different strains exist, but don't usually affect people. But then because of some genetic mutation or crossing of different strains, can all of a sudden acquire the ability just go from person to person, and in the case of some pandemics, can cause a lot of hospitalization and illness and death.
Mm-hmm. Yeah, okay. Bryna, just a comment. In terms of your question of are there things in animals that are just waiting to jump to us? Yeah, that does not necessarily, that kind of a germ does not necessarily need a mutation, as Bryna has explained. But what's happening, the risk is changing because we continue to encroach on the animal world. as we clear forests for agricultural purposes, as we expand our cities, as we damage the environment that the animals live in and they have to move around. Our contact with the wild world is increasing, and therefore possibly the risk. The second thing that I want to mention, there are many risks that are changing, but the other one that I think is critical, and this goes back to what Bryna said about influenza and respiratory illness, the capacity to move that illness around the world has increased enormously. The number of people traveling and moving all over the globe is astounding. There are between 2 and 2.5 billion, that's with a B, passenger trips per year on airplanes. Any one of which could get off an airplane with an infection and start a pandemic. So it's a huge risk. There are risks that are changing. Those are two huge ones.
Mm-hmm. Well, institutionally, what kind of arrangements do we have for, there's this thing called the World Health Organization, and that's about the extent of my knowledge of what our institutions are that are going to be protecting us. What are the arrangements that exist now for detecting a new outbreak and for quarantining it or interrupting the spread?
I'm happy to speak a little bit with the organization I'm primarily affiliated with in regards to pandemics. So EcoHealth Alliance is headquartered in New York City and works with countries throughout the world, over 30 countries. And there's scientists who are actually there on the ground, partnering with local health organizations, public-private sector partnerships, but really working with the communities to understand where the risks are most evident and what behavioral changes could be implemented in addition to science and technology, different technologies, advances, innovations, but really looking at where the risk lies based on entrenched behavior that hasn't actually been challenged in any way, but needs to be now that you have environments changing. So echoing what Ron said, global warming is resulting in increased interactions with animals. Bangladesh, where technically my family originated, is a prime example of increased interaction between human communities, which are growing in number, population is increasing, and the monkey population is also increasing.
Monkey?
The combination, that's one example in Bangladesh, yes. And so there's EcoHealth Alliance, scientists that we kind of see them as Indiana Jones. They're out there in the field protecting us from our own worst enemies, which is almost ourselves, because of the practices that we're engaging in. So petting the monkeys, feeding the monkeys, that's the kind of thing that historically has never been challenged, but that could very easily result in an unexpected and not at all what you thought would happen by feeding a monkey. But if they cut your arm in the process and then there's some sort of fluid exchange, that might be that zoonotic disease transfer that is the next emerging infectious disease. And the likelihood of that coming from some sort of animal interaction is 75% likelihood that the next big infectious disease will emerge that way. Mm-hmm. Another example is because of climate change, there are increased interaction with bushmeat in places like Africa and Indonesia and the Philippines. And that's where people are hunting meat that they wouldn't necessarily have done in the first place. But because the environment is changing and because of food security issues and because of new habitats that are accessible because they've been retreating because of these changing environmental conditions, you have people now engaging with porcupines or rats and bats and non-traditional food sources. That again is a very new territory because we don't know what potentially could emerge from that. What interaction with these animals that historically hasn't really happened could then result in a outbreak of some new disease. So EcoHealth Alliance is really at the forefront of that. It's an organization that it's nonprofit, so it counts a lot on people's perception of risk and taking it seriously, and we can talk about that later, but really is involved with partnering globally at the local level and surveying and really just keeping track of human behavior and those interactions. It's primarily concerned about.
Thank you. Okay, now Ron, maybe you can, I know you can tell me more about the World Health Organization, and then you worked in Washington on this Pan American outfit, and I know you were working for Health Canada, which relates somehow to Bryna's new organization. I understand that Bryna's organization was created as an adaptation after the SARS epidemic to be more prepared for intervention in a quick way. Can you tell me something about the structures of health organizations globally and how they relate to each other, and whether or not there's good funding, good communication, whether they're doing the right things?
That's a lot of good questions. Briefly and somewhat simplistically, if I can be forgiven that, after the collapse of the League of Nations, which was a product of the Treaty of Versailles of World War I, in 1948, after World War II, the United Nations created the World Health Organization. And it's an organization dedicated to global health with 192 member states. So it's really an organization that belongs to its member states. And every year, the ministers of health of all the states that are member states meet in Geneva, where the headquarters is, and to discuss policies and programs and global problems, etc. They have 6 offices.
Sorry, wait a minute. The heads of all of these states, or
usually the Minister of Health.
Minister of Health for each country. Okay.
Yes. And they have 6 offices scattered around the world. One is in Washington, D.C. for the Americas, another one in Europe for Europe, another one in, for example, in Manila for the Western Pacific, and New Delhi for Southeast Asia, and so on. Just to make it relevant for outbreaks, let me say that again, somewhat simply, there are 3 steps, right, for outbreak. One is find it or detect it, or that's surveillance. You got to find it first, and often the major epidemics that we've dealt with in the last 20 years are the result of an astute healthcare worker somewhere that sees a patient and says, "This doesn't look right," and they call somebody. That's the second step, reporting it. Okay, and hopefully the report filters up from local levels up to the national level and draws the attention for the third step, which is you got to do something about it. Now, the country can sometimes handle it by themselves. Sometimes they ask for assistance, and they funnel that through the World Health Organization. And the World Health Organization can respond with its own personnel or can mobilize other partners like Médecins Sans Frontières or other NGOs that can provide assistance for helping the country respond. So the World Health Organization kind of maintains a daily watch on all of the outbreaks across the world. They often call a country and say, "We know you have an outbreak problem of Lassa fever in Nigeria this year. Do you need some assistance?" The answer was yes. And people and resources are sent to Nigeria to help them set up their Lassa fever control program. WHO works through governments and is responsible to the governments because the governments pay the bill. They pay quotas to run WHO. And WHO then hires international civil servants, doctors, epidemiologists, communicators, laboratory people, vector control people, experts from around the world, and can also convene committees of experts. For example, for Zika, they convened a committee of expert virologists, and the WHO can declare that something like Zika is a public health event of international concern, and that leads to mobilization of funding from partner states and so on to control the disease. So that's a brief nutshell description of WHO.
Do they have enough? I mean, are you satisfied with the worldwide system of prevention and stopping the spread of diseases, or is it a matter of resources that need more funding or more attention, or are there other policies that need to be enacted in order to make things quicker and better and more effective in protecting us?
No, they don't have enough. I'll state that categorically. After one of their problems, they have a dilemma, a budgetary dilemma, in that the quota contributions by the member states make up about 25% of their budget, roughly. The other 75% is made up of what I call dedicated money. So the Gates Foundation wants to do something about malaria, tuberculosis, et cetera. They provide large sums of money for programs through WHO to support the countries as they fight malaria, tuberculosis, et cetera. But you can't use that money for anything else. It's in other words, it's tailored, it's limited to those things. So when WHO has a new emergency, they only have 25% of their funding as discretionary funding. The rest of it, they have to go begging for money. So for Zika, they asked, I can't quote the exact amount. For Zika, they asked for a fairly large sum of money from the member states. They got $8 million.
They wanted how much?
I can't give you the total sum, but it was tens of millions.
Tens of billions, and they got 8 million.
Tens of millions, they got 8 million.
Yeah. Okay.
Matt, if I could just speak a bit that, you know, public health is like a hierarchy. It goes from the local level to the provincial level or the state level to the national level, and then to the international level to the Pan American Health Organization and then the World Health Organization. And so really it's funding at all those levels that's really important, because as Ron said, if you can't detect something at the local level and then ensure it goes through your local public health department to your provincial or state public health department if you don't have infrastructure at all those levels, then the system can fall apart at any of those stages. And that's what we saw happening in Ebola in Africa. The public health and healthcare systems in those countries were so, in the affected countries were so poor that the outbreak wasn't detected, and then it wasn't reported, and then it wasn't passed on for many months until it had spread out of control. So really it's funding at the international level, but it's also funding at all those various lower levels as well. That's really important.
Ron, you were in charge of SARS. How quickly did it get detected, and whatever, were you able to take effective action to stop the thing as quickly as you wanted, or were there problems in just mobilizing the kind of resources and health care system that you needed?
The SARS in Canada really was SARS in Toronto. And in Toronto, the public health department in Toronto was quick to detect that there was something unusual happening. The problem was SARS was an unknown pathogen, or unknown germ. We didn't know what it was. And to find out what it was, that took time because laboratories had to do tests on samples from patients. And when you're looking for an unknown, you're almost looking for a needle in a haystack. Our laboratory, our high biosafety laboratory in Winnipeg, in a space of about 36 hours, did 300 tests for known germs, and they were all negative. So what do you do next?
What happens, excuse me, you send a sample of something, blood or something, to Winnipeg from Toronto, and they do tests for these.
Yes.
Yeah, and they're looking for viruses, or what are they looking
for? You test for the known germs that exist. So you test for influenza, you test for bacteria that cause pneumonias, because this was a pneumonia problem. and you test for respiratory pathogens that you know. But this was new. And all your tests are going to be negative because none of those germs are causing the problem. It was a new virus from an animal.
It didn't look like anything that you had before.
No.
Mm-hmm.
No. It took a consortium of 13 or 14 biosafety level 4, that's the highest safety level laboratories across the world, working together in partnership to figure out what this new virus will, first of all, to identify it as a virus, and then second, to identify the characteristics of the virus.
And because you didn't know what it was, you didn't know how it spread, you didn't know how long it took to spread, you didn't know what control measures to put in place. So that was the big challenge when SARS was happening. We didn't know, was it going around, was people spreading it before they got ill or only after they were ill? Was it from their cough, from their diarrhea, from their vomiting? We didn't know. So it was really hard to know exactly what measures to put in place to stop it from going around.
The question
we didn't know who had it either because you couldn't figure out.
The question we had in the very, very early weeks was, do we have this virus already circulating in the general public before, and they haven't yet gotten sick, because there's always an incubation period, and it was about 10 days for SARS, and so we've got a 10-day waiting period to see whether or not we're going to have 10 people sick, 100 people sick, 1,000 people sick. We didn't know. And that was a very difficult time.
Bryna, were you involved with this at that time?
Yes, I was.
And what were you trying to do?
Well, I was originally here in London. I was working here in London at the time, but a number of us from across the province and across the country actually came to Toronto to help. So at that point, I came to Toronto with a number of other people, and part of our role was to figure out so helping people. We used something called quarantine at that time. So those were people who we know had probably been exposed to the SARS virus, but were not yet sick. And so what we wanted to do was to keep them away from other people. So in case they got sick, they wouldn't be spreading their infection around. So I helped Toronto Public Health staff with developing the protocols for keeping people in quarantine and who those could be and who those shouldn't be. And we also had what we call work quarantine. So a lot of the people who were exposed during SARS were exposed to patients who were hospitalized and were healthcare workers themselves. And so you couldn't really totally quarantine healthcare workers, or you'd have no healthcare workers in the hospital to look after both SARS patients and non-SARS patients. So there was this thing called work quarantine where healthcare workers were allowed to go to work, but then they had to come home and they didn't go anywhere else, and they stayed sort of separated from their families. And public health would call people who were in quarantine every day to say, are you feeling all right? Do you have a fever? They would be asking people to monitor their temperatures. And if somebody who had been in contact with a SARS patient or who we thought was the SARS patient got a fever or got ill, then they would be sent to hospital under appropriate precautions and looked after there. So Toronto Public Health and a number of the surrounding health units did those sorts of calls daily on tens of thousands of people. And so I was involved in sort of helping to plan and be a part of those investigations. And
you had to find out whom they had been in touch with and investigate those people? Were you doing kind of a modeling of how many sociometric stars, as we in sociology used to say, the contacts that an infected person had? Yeah, so first you had to figure out who was an infected person. And as Ron said at the beginning, there were no lab tests. So it was really somebody who you knew had been in contact with somebody who had symptoms. You would say, oh, you've been in contact with someone who we think had SARS, and you have the same symptoms, so you probably have SARS. And then we would figure out who their contacts were and advise those people to stay away from other people and monitor them on a daily basis to see if they were getting sick. And if they did get sick, then to get them into hospital, get them isolated from other people. So it was that type of... How was it transmitted? Did you have to touch? I mean, if a healthcare worker gave an injection, for example, and contacted the skin of an infected person, is that how he might get it? Are there airborne infections? I would guess that an airborne infection would be a lot more transmissible and harder to control. Is that right?
Well, so at the beginning, we didn't know, but as we learned more and more, SARS was mostly a droplet. So coughing and sneezing within about 6 feet of people. It could be airborne if you had a procedure that, somebody intubated you, or if there were certain procedures that were done on you, you could make it airborne. And it probably also spread in feces, and it could have spread in vomit. And we know in some places in China, in Hong Kong, there was spread through feces going up and down in a hotel. So we know that there was a number of different routes, but the main thing we realized is that it was mostly being spread in hospitals to healthcare workers. And once we realized that and put the right precautions in place in hospitals, that's actually how we got SARS under control.
Metta, to give you some idea of the challenges for public health, I love telling about the case of a Brazilian. This was in 2016. A Brazilian who was traveling in Africa and became infected with measles. But measles is transmissible before you have symptoms. He flew back to Brazil on 6 different airplanes and caused a mild outbreak of measles in Brazil among unvaccinated people. But 70,000 contacts had to be followed up because of all those people on airplanes, in the airports that he passed through, because measles is so highly infectious that if you're not vaccinated and you're anywhere near a measles case, you'll get measles. And 70,000 contacts to follow up.
Just through the air, you get
measles? Yes.
Oh,
it's a unique challenge to track it down to patient zero. And I always reference the movie Contagion that came out a few years ago. It's been quite a few years now. Right. But it was actually, they had incredible scientists as advisors for making sure that the accuracy of the movie was there. So you had one of our scientists, a Stanford professor, Nathan Wolfe, was one of the primary advisors for that movie. And we really picked it apart. And there were a few, it's Hollywood, so you can't take the plot with a grain of salt, but the actual science behind tracking the disease from where it was back to that patient zero was actually very accurate.
Sweta, I can tell you that I saw the movie, it made me nervous.
Right.
Let me move back to an earlier thing. Ron, the first time I ever heard of you was when I watched a TED Talk by Larry Brilliant. And he was praising you for having invented this thing called Griffin.
GFIN.
Grifa?
No, GFIN.
GFIN. Sorry. Okay, good. Because he said that you had done something quite extraordinary. I guess you were in Ottawa at the time, working for Canada's health system, and that you started tracking new symptoms through watching things on the internet, and that you were able to detect the outbreak of a new disease earlier than the World Health Organization's normal system. And so he thought that was a huge breakthrough because early detection is so important. Tell me, what has come of that idea? Has it spread? Is it being used widely now? Is this the basis for your Sweta organization?
Is the first, whoops, it says my internet is a little unstable. Anyway, let me proceed. It was what happened, I'll give you just a little example. What happened was that one day in our office, this was in '96, we were watching CNN broadcast people panicking in the city of, Surat, fleeing a pneumonic plague outbreak. And it showed people just fleeing down the highways. And we thought, well, that's a long way away. That's interesting, but that's not a problem for Canada, until I got a call from our biggest airport in Toronto saying that there was an Air India flight that was going to be arriving in the airport, and the 30,000 people that work at that airport were going to go home because they thought there might be plague on the airplane. Well, there wasn't going to be plague on the airplane, but that didn't matter. It was people's perception. Make a long story short, that got us thinking about, wouldn't it be nice if we had better early alerts? And we thought, well, this new internet thing that was coming along, and people laugh now. And we said, couldn't we search that internet for outbreaks of disease? Well, at that time, the fastest search engine would take 1 month to make one pass of the internet. Now it takes half a second. But at that time, it was 1 month. And we said, no, we want reports every 5 minutes. And that's when we linked into, with a colleague, we linked into newswire feeds, because reporters will, newswire feeds. Reporters will write up an outbreak of disease in their local paper. Mm-hmm. And that can be, and that often went into newswires like Reuters, Associated Press, UPI, United Press, and other networks that would collect these and then distribute them to other newspapers. And we said, well, we'd like to get those. And we worked it out, and make a long story short, we got them. And that was the first use of newspapers as a source, as an epidemiological source. Mm-hmm. Now, a newspaper will just tell you, we've got 40 cases of this reported and we got 10 deaths. It doesn't tell you all the details that epidemiologists like to know, but it tells you that there is an event going on in that country, and it alerts you. Now, Google does it. There's something called Health Map that does it. Sweta does it. Our Sweta company scans tens of thousands of newspapers every 5 minutes.
Really?
And it's computer does. And there are several others. Outbreak News does it. There's a whole bunch now.
Ron, are you also checking for people's search criteria, what they're actually typing in and searching for?
No, Google does that, but we don't. We actually depend on the newswire feeds.
Mm-hmm. And so you were able to detect some diseases earlier than you would have otherwise been able to by quite a bit, huh?
Yeah, because don't forget, Bryna mentioned this vertical thing of information going up the line takes time. And by the time the local event gets as far as the World Health Organization, that could be weeks or longer. And the country itself might stop the flow of information because they don't want to tell people that they've got a problem, because the tourism might stop or the trade might stop and so on.
Well, that sounds awful. Now, I hadn't thought about that. How much of a problem is that they don't want to tell the truth?
Well, it's much less of a problem today because, interestingly, because of GFN, WHO changed the constitution of the World Health Organization. So the member states, prior to GFN, the member states, WHO could only act on information provided by the government. Now WHO can act on information from non-official sources. And they can call up the country and say, we know that you have an outbreak of X, Y, or Z. And we think you should tell us about it.
Ah, okay. Let me change the subject. You've made me think of something else that's a problem in my head. It doesn't really have anything to do with epidemics. But I've been very interested, in, of course, in nuclear issues for many years. And I've been told that, for example, when it comes to the Chernobyl accident, there's an enormous variation in the reporting of numbers. Everything from some stories say 25 people died of it or something. And there's another book that says there have been 1 million deaths already. It's that wide a thing. Now, I've been told that there's a deal, I don't know whether to call it a deal, but there's a relationship between the IAEA and the WHO such that the WHO cannot blow the whistle, so to speak, except with permission of IAEA, the International Atomic Energy Agency, or whatever it is. And since, according to the Non-Proliferation Treaty, the obligation of IEAE is not just to try to reduce radiation, nuclear industry, but also encourage it. They have an incentive to make it sound safer than it really is. And the IEA can give instructions to the WHO to shut up. Now, I've totally exaggerated this, and please, if anybody sees this thing, don't quote me as being the authority on this, or even being accurate in my description of it, but that there's some kind of constraint on WHO because of the power or the international authority of IEAA. Do you know anything about that? And I hope I'm wrong, and I probably am a little bit wrong anyway.
But I can't speak to that particular thing, but I can tell you that in the United Nations, there is a family of organizations. There is UNICEF for children, right? There is the United Nations Development Program, UNDP, for economic purposes. There is the FAO, the Food and Agriculture Organization, and others, major and minor, that have been set up for various purposes. And there are agreements between these agencies. For example, if there's an outbreak of disease that is affecting children, there is an agreement of, well, who takes the lead? Is it UNICEF or is it WHO? And they've worked out agreements for who has a lead and who has a supporting role. But I know those agreements exist. I can't speak to the particular one you're talking about.
Is this ever problematic, or do you basically think that the arrangements they've worked out make sense?
Is it ever problematic? Well, maybe Bryna can tell me about turf wars in public health. There are let me say that there are negotiations that take place to hammer out these agreements. Some of them are quite tedious and painful. Others are quite smooth and easy. But these are organizations that are populated by people, and people have disagreements from time to time, and people have things they feel they should be doing that somebody else should not be doing. So those things do get worked out. Bryna, do you have any? You've got experience, I'm sure.
Well, yeah, and Bryna, please give us your angle on that. Is that something that you've experienced where the change of authority are maybe not ideal?
Well, I mean, what we deal with a lot is foodborne disease outbreaks, and sometimes those will be when it's a local outbreak, so just at a local level, the local health unit will deal with it. And sometimes if it crosses, in Ontario, crosses multiple health units, then Public Health Ontario will be the lead on that. And if it crosses multiple provinces, then in Canada, the Public Health Agency of Canada will be the lead. And those outbreaks involve a number of partners because there's often animal issues, there's food issues, there's industry issues. So there we work under something called the FEORP, which is an agreement that all the partners have come to that talks about their rules and the parameters under which we operate. So those issues have sort of been sort of ironed out in a framework that we operate under, and that there always are little issues and things that arise when you have multiple players dealing with things that are emerging and arising and changing. But for the most part, we have a sort of an understanding of people's rules and how we interact in the terms of our agreement and communication protocols. So that's an example of where it works, but it works, because things have evolved over time and relationships have developed. And I think that's something that we're learning a lot about in outbreaks and in pandemic management and emergency management, that relationships are really important. It's people, it's knowing organization to organization, people to people, having a mutual respect for each other. And I think that's something that we know is very important to managing all kinds of different situations, be them local or provincial or national or international.
Mm-hmm. Okay. All right. But you're also in the business of warning people that there's a risk. Do you find I know where I'm going with this. I think I want to hear Ron and Bryna in terms of your notion of how difficult it is, or maybe the opposite. Maybe people, when they hear there's a danger, maybe they panic and they really do run down the street fleeing. Or my guess is that it's the opposite, that they tend to discount any warnings. But at any rate, the question of how successful are you, and what are the obstacles in warning people to change their behavior in order to prevent catching whatever infectious disease is floating around?
Well, I can start. I think there are certain things we know make people overreact about risk, right? So if something is new, or it's highly lethal, or it affects your children, or we don't know a lot about it, those are the things that make people sort of overreact to risk, where sometimes that's justified, and sometimes it's sort of an overplay of the facts, maybe because we don't know all the facts. But there are other things that we know that cause lots of risk on an annual basis, an ongoing basis. So things like influenza, as an example. We know that regular flu every season kills about 3,500 people in Canada a year. But yet people, because it's sort of seen as regular and routine, and people don't perceive their own risks, they don't maybe know someone who died necessarily, or it's generally older people who die, and maybe that it's not appreciated that flu has contributed to that death. So people don't, in that case, don't appreciate the risk of influenza, don't take all the precautions like getting vaccinated every year. So in some cases, when it's new and not a lot of understanding, and a few cases are, show up in the media as highly fatal or fatal or very severe, those sometimes get over responded to. But things that are more usual, but then in totality cause more deaths, but they're sort of regular run-of-the-mill, they sometimes get underperceived in terms of their risk. So I think it's, people are very complex about how they manage risk, and everybody's different. The same two people won't perceive risk the same way, even with the same set of parameters.
I'm a sociologist, and I remember reading stuff about the sociology of disasters. And it seems that the most typical thing that happens is that the authorities say there's a high dam that they know is probably going to break and wash everybody away. They may go up and down the street with a megaphone saying, run, because this dam is going to break and you're in mortal danger. And that, if anything, the tendency is for people to simply not pay any attention, to just discount it and not believe that it's real. And certainly we know that when it comes to global warming, at least maybe not everywhere. I think certainly in the US that's the case, but I don't know that it's true in other parts of the world. I think everybody else in the world understands that global warming is real, but there are plenty of Republicans who don't believe that. So I think maybe that Sweta, can you tell us a little bit about the psychology of denial and what has to happen in order to convince people that there is a real risk?
Sure. So it's interesting you compared it to global warming, because I almost pit those two as very opposite threats that the public has to face and come to a conclusion about. And global warming is extremely polarizing for various reasons. Like you said, whatever your political tribe might be, how you identify yourself can influence to what extent you perceive it to be a threat. Infectious disease is almost the exact opposite. It is, because it's not so salient until it is, it's not nearly as polarizing. And that's a blessing and a curse. It's a blessing in that those who are working on it don't get the same sort of pushback compared to those environmentalists or experts who are trying to take some real progressive policy action for climate change. But you don't get the same sort of pushback. But at the same time, because there is a lack of awareness of the issue as compared to other catastrophic salient threats like nuclear and like climate change, you're also not getting the attention that you need and want to also see some of this policy progress. So a good example of this is vaccination budgets. And we experts have been calling for a universal flu vaccine increased budget to develop that for years, and it's always been underfunded. I think last year it was something like 64 million was spent on this in the United States. A proposal just came in to Congress for $1 billion over the next 2 years, which is a great increase in developing this. That widespread consensus is that it's very much needed. But because it's not so salient, it's sort of hard to convince the public that this is a necessary spend to protect themselves against a massive potential threat to their health and well-being. So there's both sides of this. You want people to pay attention, but also you don't want people to take such a strong opinion that you won't be able to move forward based on science.
Yeah, if I may, Metta, I like to think of two situations in which there is a real emergency and people will have to do something, and when there isn't a real emergency, but there might be. In other words, the threat of one. In the real emergency situation, I can't underestimate the importance of a trusted spokesperson because there's an axiom in emergency management, which is the most valuable thing that you could lose is the trust of the public, because you need the public to believe you when you say you need to be vaccinated or you need to shut the door or you need to stop whatever. That's the emergency situation, a trusted public spokesperson. And scientists are not usually very good public spokespeople. They get too scientific. In the non-emergency situation, perception of a threat, I think, is important to think of it in terms of, is it a distant threat? Sweta, the global climate thing, when people say, well, half of Florida is going to be gone by the year 2100, well, who cares? I mean, right now, because I'm not going to be around in 2100. So there's a lot of, perception of a distant threat. And to do something about that is really difficult, I think, for humans, and especially for politicians whose horizon is the next election. And then there is the dam you talked about. The dam is going to break, and that's a threat, imminent threat. You're right. Some people will respond to that, and others won't. When we had the big forest fire that burned half of Fort McMurray, and people were told to evacuate, they did. I mean, they could look out their window and see the flame, and they evacuated the whole city. So it all depends. It depends on so many factors as to how people perceive risk.
Mm-hmm. Okay, I want to wind up very quickly with because very shortly I need to speak about something else. But in terms of recommendations of public policy, I'm collecting suggestions for public policy innovations that actually would reduce the risk of pandemics. Can each of you propose just one thing that could be done on a global scale? Maybe something the WHO could do, or maybe something that needs to be done to empower the WHO to do better, or maybe something that should be done at the local level. No, I want it to be a global scope. Can you each propose something that will actually help reduce the risk of pandemics?
You don't mind, I'll jump right in because it's a favorite topic of mine. First of all, I don't think we can stop pandemics. They will happen because we live in a biological world. What is important is how we manage them. And if I had my best wish, every single nation in the world would subscribe to and employ the incident management system for the response to an outbreak of disease. And that the World Health Organization, through their emergency response new program, I know they are promoting this globally. It's going to take a lot of training and effort to get the system across the globe. But the better we manage it, the less impact it will have.
You say incident management system?
Yes.
Can you elaborate?
It's a system developed, interestingly, by California firefighters, because they were dealing with the huge forest fires in California and they had to bring out multiple fire departments and the hoses didn't fit and the systems didn't fit together, and they couldn't talk to each other on the same radio frequencies, etc. So they came up with a system in which for any outbreak, there was one incident manager who was in charge. And there are at least 4 major components. One is a technical component, usually. For an outbreak, it's epidemiology, clinical care, etc. There's a logistics, because for an outbreak, you might need to get some vaccines ordered and cholera treatments ordered. There is finance, because you need money. And there is planning. And so when you populate those 4 elements with an incident manager and some ancillary people, you've got a system in which you can actually communicate across the different disciplines to manage and bring an end to an outbreak.
Thank you. Okay. Sweta, your turn.
Sure. So I think we need to take a One Health approach. We haven't actually mentioned that yet, but it's very much the ethos of EcoHealth Alliance and myself as a multidisciplinary advocate of various sciences coming together. It's really important you bring in all the different skill sets from the veterinary health sector, from human health, from environmental understanding of how we're interacting, all of us, with the environment and with the species we share this planet with. And once you look at it as a One Health approach, is what it's called, and you begin to apply all the different science skill sets that doesn't just look at the science and technology advances, although that's critical and important, but also looks at those behavioral interventions that are much more cost effective, better scaled. It can be learned from one community, how behavioral changes are going, and then applied across globally. And so a big proponent of applying the One Health approach towards pandemic mitigation.
Thank you. Okay, and Bryna.
So I guess I would say robust and global early response detection and response capability. So it's really a strong public health infrastructure across the globe. It's really, people say that public health is only as strong as its weakest link. And so you really need to be able to detect these outbreaks as soon as they emerge so that they haven't spread widely. And then you're sort of trying to clean it up at the end, detect them early, and have robust and very capable capacity to respond.
Thank you. Well, all 3 of these will definitely go on to the accumulating list that will become the platform for survival. And I need to explain that a little bit if you haven't watched one of these shows before. The purpose of these shows, or one of the purposes, is to inform people who are going to participate in a forum that will take place in Toronto. It's called How to Save the World in a Hurry Forum on May 30th and 31st at the University of Toronto. And the purpose of the forum itself is to select 25 public policy innovations that will, taken together and simultaneously, reduce the risk of 6 global threats. I'm thinking of war and weapons, especially nuclear, global warming, famine, pandemics, massive radiation exposure, such as a reactor explosion, and now cyber attacks. And some of the same measures that would be good for reducing the risk of one will also be helpful in reducing others, because these threats are to some extent interdependent and causally linked as a system. And there are also some societal changes that need to be made in order to facilitate the adoption of the proposals, the 25 proposals that will be on our platform for survival. The idea of the platform for survival is that it will be something that can be shared by a number of different professions and NGOs, people working in areas that don't necessarily have much contact with each other, but the effectiveness of their work to some extent can be interdependent. And by having a common platform, they can actually accomplish more and have their eye on the same goals and work toward the same purposes. So we think that there's value in having a common platform, but it needs to be chosen very wisely and it needs to be informed by people who know what they're talking about, such as our three panelists tonight know a lot about the problems of pandemics. Every week now, every Monday evening, I'm holding a conversation like this about one or at least some part of one of these 6 global threats, or some of the other changes that need to be made to in global governance or in finance, international finance, or in other institutional changes that need to be made in order to create the conditions for these other solutions. So without being too obscure, I want to invite you to take a look at the website for that project, How to Save the World in a Hurry. The website is called tosavetheworld.ca, and you can see there a bibliography, you can see a discussion column, you can see a whole bunch of links to videos, and you can see the accumulating list of proposals from which the platform itself, these 25, will be selected. So if you're interested, you can go to that site, and we have there will be a registration fee for attending the conference. People will pay mostly $120 for the 2 days, but if you do have a look before the 30th of April, there's an early bird price of $100, or if you're unwaged or a student, it's $40. So go have a look, and if you think that this is something that you'd like to participate in, please let me know, or please just register. I want to see as many of you as possible at University College on the 30th and 31st of May. And I want to thank our panelists tonight. You've been wonderful, and this video will stay online for a long, long time, and you can ask your friends to come and look at it if you think it's useful and informative, which to my mind is extremely helpful. So thank you all very much, and I hope to see you on the 30th and the 31st of May at U of T. Thank you.
Thank you.
Thank you. Good night.
Night.